Well, I'd like to welcome Dr. Jason Hawrelak to the Resilient Biome podcast. Thank you so much for being here.
You're very welcome, Rich. It's a pleasure to be here and chat gut and microbiome, two favorite topics.
Fantastic. Well, I imagine most people tuning in know who you are, but just to make sure, I just want to read a bio so people know your background. Dr. Jason Hawrelak is a researcher, educator, and naturopath with over 25 years clinical experience. He did his PhD examining the capacity of probiotics, prebiotics, and herbal medicines to modify the gastrointestinal tract microbiota in the early 2000s and has taught widely, both in Australia and internationally, on these topics for the past 20 plus years. Jason has maintained a busy clinical practice for over a quarter of a century in both Hobart and northern New South Wales in Australia, and now teaches primarily within the Microbiome Restoration Center, where he is lead educator for a range of online practitioner trainings on the microbiome and gastrointestinal health. So I'm sure there's a lot more that could be said, but that'll suffice. And we'll jump into some questions here. But first of all, I knew you actually through your wife Dawn,
Yeah.
and I knew you're associated with Gould's Medicine. Are you
Yep.
also still working through Gould's and Microbiome Restoration Center as well?
Yeah. So the Microbiome Restoration Center is sort of my new educational center, whereas Gould's is still I'm still one of the owners of Gould's Natural Medicine, which is a business in Hobart, Tasmania, 1881. It's been around selling natural medicines, so it's got for Australia a long history. And we've got a medicinal herb or organic herb farm, and we make a lot of our own medicines down there too. So my clinical practice is all virtual these days, but it's still within the sort of Gould's envelope. Yes, still.
Okay, because I noticed
Yeah.
in the Microbiome Restoration Center that you can locate a practitioner there as well.
Yes, that's right. Because essentially, one thing that's I suppose as you're aware, the research on the microbiome has increased in the last 20 years. And when I started my PhD, well, my honors degree and PhD was end of 1999, and I could read every single paper on the microbiome and every single paper published in the
Wow.
previous 2 decades.
Wow.
For as part of my thesis for my honors degree.
Mm.
And you fast forward, it's just it's intense how that's actually shifted. And I think essentially 20 years ago, you used to be able to get by as a clinician working with patients with a little bit of knowledge of the microbiome, and that was okay. Whereas I think that's changed. So my passion now is educating clinicians to become microbiome literate clinicians about okay,
Mm.
what best tests to order, how to interpret those tests, how to modify and optimize the microbiome, and be aware of the interventions you're prescribing, whether it be dietary or herbal or pharmaceutical, and the microbiome impacts. Because I think we've kind of shifted from, you know, 30 years ago, humans were beings that had microbes that may or may not have been important, is certainly the view of Western medicine at that time, to now where these holobionts, where the microbes are super key, like vital to who we are and what we are. We are this being that's composed of human cells and microbes, or non-microbe cells and microbe cells working in unison that creates a human. And because of that shift, we can't be ignorant of the microbiome anymore, and for unintentionally causing it harm, it's a problem. So I'm really trying to upskill clinicians about okay, how do we look after this component based on what we've learned over the last 25 years? Yeah. And and partly because you see clinicians who, I mean, just um, trying to get through the field, but that without any extra training and actually inadvertently causing harm to patients. And I see that not infrequently in practice. And it's not intentional, it's just that they just don't
Mhm.
know, and that, so 20 years ago, there's a lot of stuff we didn't know, but geez, we've come so far. And do we need to learn tons more? Yes. We get a microbiome readout from someone. It's like, we know what maybe quarter of those species do, and a whole bunch we don't. So, that's going to, and that is constantly expanding, thankfully, as our knowledge grows, we learn more about different microbes and whether they're beneficial or not, how to modify them, etc. But yeah, going back to that, my passion now is really about trying to educate clinicians to become more really microbiome literate, because that's really, given the microbiome plays a role in cancer and heart disease and aging process, and almost every disease you can actually list people in Western nations suffer. We it's imperative that the microbiome is a core part of our treatment approach. It may not be the only thing we're doing, might be working on a range of other things too, but we can't ignore the microbiome or implement other strategies that are causing it harm and expect to get good results with our patients long term.
Thank you for that. So a little less time as a practitioner, a lot more as an educator at this stage.
I'm morphing. I would say
Okay.
just as of just a couple weeks ago, I've dropped one of my clinic days to spend more time in the educator role. Yeah, whereas I've felt it was if you look back over my last 25 years, I've always practiced in that time and seen patients. I've taught from most of that time too, starting off at Southern Cross University in their undergraduate naturopathy course to University of Western States doing their Masters of Human Nutrition and Functional Medicine, where I taught their gastroenterology unit. And then at University of Tasmania in the School of Medicine, just teaching evidence-based complementary medicine. So education was always part of that, but I think it's always melded well because, and I'd say particularly now because I focused solely on teaching around the microbiome and gut, and that's all my patient cohorts are that too. So it really feeds each other really well. And because I want to, have to stay up to date to teach my students, it means I'm keeping up to date with the literature, and it means I get a chance to trial new research findings out on patients. They're going, hey, this study came out. This looks really good, exciting. Let's trial it and see if we get better results compared to other things that we've been doing. And I think being in that position where you're having a chance to utilize things that have been researched and seeing the impact as essentially being a clinician too is vital because the number of things in research studies work but don't work in the real world, or the dosage is totally wrong, or you have to introduce it in a certain way, and you don't have that knowledge unless you're a clinician. So to me, it's all fed into each other really well, the researcher, educator, and clinician, and hence what I'm going to keep doing at least probably all three onwards, but I'll focusing a little bit more into the education because it feels like you can reach, like I can see a number of patients a week, but if I educate clinicians, you can treat hundreds of thousands of patients a week and improve their lives that way. And it just seems like a good use of my time and energy at this point.
That makes sense. Yeah, you're multiplying
Yeah.
your efforts. Yeah, that's
Yeah.
wonderful. All right. You mentioned how the gut relates to almost every disease state. Is
Yeah.
there in all the massive research, and that's amazing the way you described that you could read all the papers back then. Is there any access, gut brain, gut heart, gut lung, that is maybe the most researched or best understood, or are they all pretty
Uh,
equal at this stage?
well, I mean, I think there's areas that are expanding. Um, I still think sort of, maybe gut is probably the best research because that's where we started off in terms of the role of the microbiome in different gut disorders. But I think,
Hmm.
it's like the gut metabolism, gut brain are probably the other areas that have got a fair bit of research that's really bloomed in the last decade. Gut kidney disease stuff is like that's really blooming too. Metabolic disease. It's like, yeah, there's like so many different areas are really blooming now. But I still think the sort of gut microbiome and gut diseases is still probably would be the head of the queue or the biggest number of publications done over the last 30, 40 years still.
Thank you for that. Speaking personally, it would be the gut-lung axis that has been the biggest impact for myself. I had
Got
sort of
it.
a mild asthma, and through diet, gut health, and then eventually nose breathing, I got rid of pretty much my asthma. And I can tell though, there's a time my Bifido crashed, and I found my asthma returning somewhat.
Interesting. Yeah.
But if I get it above a certain level, and there could be other bacteria that would do the same thing, but I noticed it was the bifido levels that really made the difference. So,
Yeah, I
so
think
I
there's some.
experienced that.
Yeah, and I think there are some species that we would call keystone, or other word would be less redundant in that like we know that there's a fair bit of redundancy in the microbiome, which means that there
Mhm.
might be 15 different species that make butyrate, and if you have some of those, then you'll probably be fine. We don't necessarily know for sure that some like roseberry is definitely better than Eubacterium, definitely better than Anaerostipes at this point. Yeah, but we know that they have that sort of functionality. But I think there are others whose role is more pivotal, and that when they're lacking, there are more repercussions because nothing else steps up. And in the same way, it can do the same job in the same way. And Bifidobacteria would fit that category for me. Akkermansia would fit that category. Faecalibacterium would fit that category too. Yeah. And you might even put Oxalobacter too, even though it's a really small player. For some people, its role is just huge as being their only sort of oxalate degrader bacteria in their ecosystem. And when that's gone, there's a lot of deep repercussions from a dietary and lifestyle perspective. Yeah. So even though it's really it's only there at like 0.01 or 0.1% of the ecosystem, it's a tiny player when it's there. But just for many people, this plays a pivotal role in helping to degrade oxalates that nothing else can do when they're missing that bacteria. Other people have got other microbes that can step up and do the job, but some people don't.
I love that idea of redundancy. Think about most things in the human body don't have that level of redundancy.
Yeah.
It's either works or it doesn't work. So that's really fascinating.
Yeah, and I think that's one of the reasons why, researchers have always talked a lot about the importance of diversity of the microbiome or having a diverse microbiome, because the idea there is you have more built-in redundancy, so that if you do take a course of antibiotics that wipes out, three species of butyrate producing bacteria, if those are the only three you've got, you're going to be a bit stuffed. But if you've got seven others that haven't been impacted by that particular antibiotic, it may not actually make a huge difference to your day-to-day functioning. Yeah, and you might be able to still live a very happy, life without those three species. And some antibiotic courses won't make things go extinct, but we know that is a not uncommon consequence from antibiotics. There's one paper published in Gut that showed 9 species went extinct from one course of intravenous, antibiotics. It wasn't even given via the
Wow.
gut, but nine species went extinct forever from that one course. So some antibiotics definitely have, permanently dramatic altering effects.
And I'm sure some of those species must naturally return, or what's the typical result?
Most of the time, you will see after a course of antibiotics, you see a major disruption. Yeah, and about 4 weeks afterwards, it's reestablished into something new. It's not the same as it was before. Yeah, it's similar-ish. Yeah, some species may have gone extinct. Some species will slowly have come up over those 4 weeks. Some things have got a major leg up because they had antibiotic resistant genes, and they were like super dominant for the first number of weeks while the competition wasn't. But usually about 4 weeks afterwards is something new, sort of base like that's stable again. Yeah, and then it won't necessarily change another 4 weeks later. It won't necessarily be much different at that point. But that initial 4 weeks is pretty hugely different. But it does differ a bit per antibiotic. Some like, rifaximin has got relatively mild impacts. It still impacts, butyrate producing species, and it does seem to decrease diversity. But about 4 weeks later, it seems to look pretty normal. And then you have ones like clindamycin or ceftriaxone, and where it's like, oh, it's never the same after that. Yeah, and dramatically
So the
different.
species that rebound were they still there in tiny amounts?
Yes,
Must have
yeah.
been. Okay.
Yeah, and that's how we can sometimes, work on improving different people's diversity, where we'll do a microbiome assessment, like, oh, you've got 100 species present, and then we do this other work without necessarily intentionally introducing new species in, but we're going, let's have more fiber, let's have more polyphenols, let's exercise more, etc., whatever the case may be for that person. The next time we do a test, there's 160 species there. You're like, look at that, and they just magically appear. They were always there, but below detectable thresholds, because all of our testing has got a limit to how well it can see things. So things that are below that threshold, we cannot see currently. But when we feed them up to the point where we can see them, then we can, and they're going to be at the point where they can be contributing to your health in that kind of level.
Hmm. Yeah, related to that, I've heard you say most probiotics don't colonize in the gut for very long, or sometimes not at all. And so I was always wondering, so if I take, and I only started taking a probiotic about a year ago.
Yeah.
Say I'm taking a B. longum probiotic, and it doesn't colonize, but I've got I think the last time I checked, at least 6 or 7 different species of
Bifidobacterium.
Bifidobacterium.
Yeah.
So, silly question, but where did they come from? Because they must have colonized at some point, but modern probiotics have a difficult time colonizing. So help me understand that, please.
It's a great question. And I have students ask us all and patients ask us all the time over the last 20 some years, because we've known for looking at research in the 70s, 80s, 90s, 2000s onwards that probiotic strains we're using do not permanently stick. They don't stay there for months afterwards or years afterwards. It's not as simple as that. They generally will, maybe some strains, good strains, will stick around for 7 to 10 days or 2 weeks, and a diminishing amount each day that you sort of after you stop taking it. There's rare, one study with one strain of Bifidobacterium. I think it's the AH. 1206 strain from memory that persisted. The only one I've seen persist for like 6 months in 30% of people in the study. And that's like, wow, that's like by far the best outcome we've ever had. And they argue there's probably two things. One, there was an ecological niche available for the Bifidobacteria in those people, and two, that particular strain had better staying capacity. Those are kind of the theories behind it. But it is an interesting thing because we're isolating these probiotics from humans where they are inhabitants and permanent residents, and then we're kind of putting it into supplements and then giving it to other people, and they just don't stick. Yeah, and would they stick in that person's family? Possibly. And I think this is the thing we're still missing some of those little details there of going, so if we took that probiotic from microbe we isolated from let's say it was a mom and then gave it to the kids, it would stick most likely, very much will likely stick in them. We also know that if we give the probiotic to the mom during pregnancy or the last bit of pregnancy, that strain can permanently colonize the infant moving onwards. Yeah. So there is a window at which we can. And there is some research on some like Bifidobacterium infantis strains that can permanently stick to. So that's probably another exception to that in that population infantis strains, with human milk and HMOs can actually establish really strongly and permanently colonize. But we don't tend to see that with other strains of lactobacillus bifidobacteria in that age group or in adults per se. And it has been a bit of an unanswered question, and some. Taking a step back, even FMT, like we're taking the whole ecosystems, they don't always engraft either. And researchers still don't know why. Even if we pick the people with the best poos possible, like the really super donors, and we give them, only a proportion of the people will engraft properly. Some will partially engraft, some will entirely not engraft at all. Yeah, and the people who it doesn't engraft, we don't get any sort of benefits from it, which is not surprising, even though those, often you argue they have better staying capacity than your typical probiotic supplements, because they definitely do. So there's still reasons we don't know, and I've been to enough probiotic conferences where people are still theorizing about this even now, like, oh, maybe if we focus so much, like if we spend all of our time trying to isolate a bifidobacteria strain that did permanently colonize, we might get there. The criteria has been, surviving gastric acid and bile salt and um, being able to attach in vitro to colonocytes, um, and having shelf stability. Those are probably sort of the four sort of major criteria that people have been choosing probiotic strains with. And maybe if we chose another one, okay, long-term human colonization capacity, and we kept researching, we might find some that have got better capacity. But I think even then, there's still unknowns because we just don't know why things will engraft better in some people than in others.
I've heard actually introduced by your wife, Dawn, B. infantis EBC001
Yeah.
must be one of those exceptions.
It is, yeah, in that age group, definitely is, yeah. And I've seen it even, and this isn't necessarily based on research because most of the research has been in that age group, but I've seen it even in toddlers being able to permanently colonize too when given a lot of HMO support too. Yes, so I think yes, that is one of those exceptions.
That says a lot based upon most that don't. Yeah.
Oh yeah, yeah. I mean, there are hundreds of studies showing essentially a lack of long-term capacity. While you take it, sure, it shows up in your poo, but you stop 2 weeks later, it's gone. Yeah, and there's other microbes like E. coli, the Nissl 1917 strain that, there's research showing that in some people will stick around for a number of months afterwards too. So that another is a partial exception, that it will have a relatively long colonization capacity compared to lactobacilli bifidobacteria based probiotics.
Yeah, fascinating. Thank you. In all your work as a clinician, what have been some of the more, we would say, straightforward GI microbiome issues that tend to respond to treatment pretty more easily, at least?
Well, I think of conditions that we see dysbiosis as being a key driver of. I would also have colitis in that category. That I love working with UC patients because they usually respond so well to dietary work, microbiome modification, herbal medicines. I get very good results with ulcerative colitis and other types of colitis like collagenous colitis and lymphocytic colitis, etc. Too, are in a similar category. Um, And irritable bowel syndrome too, interestingly enough, is actually in a condition, and maybe because my PhD was in IBS specifically in the role of dysbiosis, a dysbiotic ecosystem in IBS, and how we could change that ecosystem in this population using herbs and pre and probiotics. That's been a key passion of mine, a key patient cohort I've worked with for over 20 years, both as a research scientist and as a clinician, that I've a lot enjoyed working with that population too, and feel like we have a good, high rates of success. And I think even just what I see relatively simple things like antibiotic associated diarrhea, antibiotic associated ecosystem disturbances, particularly early on, I think are great to work with too. Like sometimes like years later, they can be sometimes could be, have more tricky aspects to them too, because of what may float on from dietary choices, other interventions, etc., that may have made things more complex and harder to deal with. Yeah,
Well, I
but those
imagine
are groups
people,
I think respond well.
yeah, thank you. People with ulcerative colitis listening to that, you give them a lot of hope for sure.
Yeah, well, I mean, again, if you look at the, and again, I'm lucky enough to teach dietary influences on ulcerative colitis for over 20 something. One of the first lectures I gave was on that topic back in probably 2001, and even just piecing together all the dietary stuff back then, we like, yeah, there's a genetic component, but geez, it's like gone up 20-fold in this small period of time. At eight
Wow.
genes that's doing that. It's lifestyle and diet that's doing that. And yeah, and there's been so much work done in that area, thankfully. And yeah, if people are able to implement the dietary changes, etc., we tend to see really good results in terms of getting people in remission or keeping them in remission long term. So it is a condition that I enjoy working with for sure. And I think yeah, even and SIBO too is one condition, particularly hydrogen SIBO, I think tends to respond generally for majority of people relatively well to treatment. Methane SIBO, on the other hand, or clonic methane overproduction, or IMO, it's more hit and miss. That for some people responds beautifully, really quickly, and other people it's like very slow. It's a slow beast to tame, as I sometimes tell my patients, because it can just take months of continuous treatment to sort of budge the methane. And whereas other people, 2 weeks, and they're pooing like champs, and their bloating distension's gone. You're like, great, I love those ones. But it's definitely more variable in terms of treatment response as a condition.
And some of the more, you mentioned the methane SIBO, any others that are particularly challenging?
I would say in terms of maybe probably patient cohort, but those to come to see me that have been on like carnivore type diets or really plant restricted diets, those ones are really hard too because their guts are really, their microbiome is usually really dysfunctional, compositional wise. And there's usually a high degree of what I call visceral hypersensitivity, that the nerves in their colon are so inflamed and so
Mm.
sensitive that even a tiny bit of gas production from a plant causes them pain and discomfort, so it can be really tricky to try to, particularly if they've been on it for 2 years or something. It's like those patients are really, really hard because we have to try to decrease the inflammation, visceral hypersensitivity, while at the same time they're eating foods that are causing it, because that kind of dietary protocol feeds hydrogen sulfide gas producing species and produces lots more hydrogen sulfide gas, and that causes visceral hypersensitivity and prevents colon cells from being able to utilize butyrate, and they're also eating a diet that doesn't make any butyrate. So, and starving out the butyrate producers is this horrible, perfect storm of events. And that population is really tricky to bring back. And you just wish that it came to see you 2 years ago when it wasn't, rather than 2 years down a path that's actually caused them a lot of gut and microbiome harm.
So you can't really give those patients prebiotics, or
You
maybe
got to
certain
very
ones.
slow. Yeah, and it's
Okay.
very hit and miss going, okay, let's do a tiny pinch of PHGG, the tiniest pinch of 2FL, like a human milk saccharide, or maybe we'll try a little bit intrarectally, like sometimes, and we have to go with preformed butyrate, rather than actually, because they might not have much in the way butyrate producers, and we can't feed them because if they will produce gas, and the gut can't handle any gas anymore because it's become so sensitive to any sort of change in the gut environment. It's a really tricky patient cohort to work with. Yeah.
Mm. Speaking of prebiotics, especially, or probiotics, any of those tend to bring the most help to patients in dysbiosis?
From a microbiome composition perspective, broadly speaking, prebiotics are definitely far more effective at changing the microbiome in broad ways. Yeah,
Mm.
it's not to say that right after course of antibiotics, right after course of chemotherapy, where there's a really acute disruptive event, that probiotics can be immensely helpful in that situation to help bring a bit of stability and balance in that scenario. Yes. But in terms of making, huge changes in microbiome composition, probiotics don't. Really, you take a probiotic, you'll see some small nudges in a couple of areas, maybe, depending on what strain you're using. Whereas if you give the right prebiotic, you can have 1,000-fold increase in Bifidobacteria and 100-fold increase in um, lactobacilli, or a 10,000-fold decrease in Bacteroides. Like, you can have these massive shifts from using the right prebiotic in the right dose that you will never get remotely close to achieving with probiotics.
You
You could look
explained,
at the research on probiotics and impact on the microbiome, and it's really across the board pretty minimal. Yeah. So it's not the reason I'm generally giving probiotics is to modify the microbiome. It's because maybe they speed up transit time, or maybe they're a psychobiotic that can help improve anxiety or depression. Maybe because they're good for gut healing. There's a number of reasons why I will give a probiotic, but not to positively modify the microbiome so much. Although there are some exceptions where, some strains like Lactobacillus reuteri DSM 17938, which is the BioGaia product around the world. That strain does decrease methane production in the gut, and it does decrease Proteobacteria count in the gut. And we have human studies showing that. So yes, it'll have some role to play there. So there are some relative exceptions to that, but still the impact, broadly speaking, on the wider community of the ecosystem will be far, far less than with any prebiotic.
yet that's what's on all the supermarket shelves is probiotics.
Yeah, and I think prebiotics bring their own challenges because most of them will cause an increase in intestinal gas production. And for those of us whose guts are working well in terms of transit time, we'll just fart more. And that can be a slight inconvenience to, depending on your work situation, more so if it's just increased flatus, versus those people whose guts aren't working well. If they have slow transit time, or the nerves in their gut are inflamed, then that intestinal gas will cause them to expand outward and experience pain and discomfort with it. So they're not as safe as an off-the-shelf thing that everyone can just tolerate well, because so many people in Western nations are constipated and have slow transit time. Yeah.
Mm.
So many have a degree of visceral hypersensitivity, so they're going to react to those things. So they, whilst they do have this profound capacity to alter the microbiome, you have to be almost, selective in terms of their use. Whereas probiotics, there will be people who don't tolerate probiotics too. I've seen them, you would have heard the stories too, but the vast majority of people tolerate probiotics really well. Particularly if you're looking at general healthy populations, they tolerate them really well and don't have it might be slight change in some discomfort, not discomfort, but in some gut feeling when they first started or something, but they're generally tolerated really well.
Mhm. You described my experience perfectly. I radically changed my gut only through prebiotics.
Yeah.
I was like 3 or 4 years into it before I touched a probiotic. Very powerful. Yeah.
Yeah, and I don't take a probiotic daily. Yeah, but I do take prebiotics daily, and I have
Mm,
for years and years. But do I
mhm.
take a probiotic if my young daughter when she's younger came back from daycare or child, school when everyone else has got viral gastroenteritis? Yeah, I will at that point. Or should I have to expose her to something that might be causing microbiome harm? Yes. Or travelers traveling to Southeast Asia, where I'm a high risk of travelers diarrhea. Yeah, there are certain times I'll definitely take a probiotic, or even during cold or flu season where I'm going to be working with people or around people that are sick. I will take the right probiotic to help protect me from my boost my immune system to help protect me getting sick. But I don't take one every single day. But I do take prebiotics daily to, boost my beneficial bacteria. And we know, I'm in my early 50s now, and generally what we see in Western nations anyway is a reduction of beneficial bacteria counts as people age. And I don't think this is something we generally see in by default. But it does happen to Westerners. And it's like, I don't want that. I want to keep my good guys powered along in great amounts. So prebiotics are a definite part of my daily routine until I pass on. So hopefully another 50 years from now.
Yeah, for sure.
Yeah.
Speaking of prebiotics, what is your favorite prebiotic and why is it HMO?
Not
Sort
HMO.
of sort of a trick question.
I know.
That's my favorite. What's your favorite?
I'm gonna have to say there's two because they're just quite different. Lactulose is my favorite prebiotic
Mm,
for dramatically altering the ecosystem. It reduces levels of Proteobacteria immensely well and reduce the levels of overgrowth bacteroides immensely well, which are things we see commonly in Western nations. And it can also be used for high levels of Prevotella too. Feeds Bifidobacteria, feeds Faecalibacterium, higher doses feeds Lactobacilli, and also um, sometimes Akkermansia too, not always Akkermansia, but sometimes yes. So it has an impact, but in terms of its capacity to reduce levels of pathogens and pathobionts, there's no other prebiotic that comes close to it.
Mm.
Like you get like 10,000-fold decreases of some pathogens. It's just like it's really amazing stuff. Plus you can use it for as a laxative in higher doses too. So it does have its applications there. Um, but then I also like partially hydrolyzed guar gum because of its broad tolerability. Yeah, so PHG is tolerated by vast majority of people. Yeah, at therapeutic doses. Not everyone. I've got patients who don't, or we have to start with a pinch and then build up over 2 months to get to like a close to therapeutic dose. Um, but I do work with a very sensitive cohort these days. But what I like about PHG is that we can use it in diarrhea, we can use it in constipation, and it has like a normalizing effect on the gut. It can either speed up transit time or slow up transit time, depending on what we kind of need it to do. Um, Blends easily into things too. So it's like really easy to mix into, from a practicality perspective, it's hot drinks, cold drinks, smoothies, yogurts, breakfast cereals, any of those things works for PHG because it has no flavor and it's very soluble. But it also feeds butyrate producing microbes. And I think that is also a really cool attribute that it complements other prebiotics like lactulose or inulin or GOS in their great capacity to increase bifidobacteria. Whereas PHG, a little bit bifidobacteria, sure, but you don't get these like 100 or 1,000-fold increases with bifidobacteria with PHG, at least not in my clinical experience. But you do get blooms of a range of butyrate producing species, yeah, in a way that's usually well tolerated as well. Yeah, so it can be a great one to start with those people that have more sensitive guts to broader increasing their fiber intake. Because sometimes you can look at a microbiome and go, what you need is you need a ton more plants, a ton more fiber, lots more variety, lots more polyphenols, but they can't go there right now because they've got the transit time's really slow. They've got visceral hypersensitivity, so any sort of fibery type things will cause any gas production will cause discomfort, pain, bloating, slowing of the bowels. So you have to work so slowly. You can't do much dietary stuff initially. Some things you can do, but a lot of stuff you can't do, even if that would fix the microbiome perspective. It's like it's going to make their life a living hell. Well, you do that to that point. So whereas PHG is a lovely thing for many of these people you can introduce and slowly build up, sometimes relatively rapidly, and then start increasing butyrate production, feeding those butyrate producers. And butyrate can then heal the damaged, inflamed colon cells, help improve motility. It can also help change the ecosystem because of the acidity to help enhance the growth of other beneficial bacteria. So it's a very useful supplement in that sort of population for sure. And that's the other reason why I use it heaps. And you can use it in hydrogen SIBO and methane SIBO too. Again, not across the board with every patient, but in general, yes, generally safe in IBS. Like we did a systematic review of clinical trials on PHTG in irritable bowel syndrome patients, and every single study shows that it works. And it's one of those ones where it's like I didn't know PHTG existed until like 2015, so like 10 years ago, never heard of it. And I started reading the studies on it. I was like, oh wow, this stuff sounds interesting. Every study's positive. I want to bring it in. So at that point, you couldn't get it in Australia, so we started bringing it in from the US and using it in our patients. And the results were just absolutely brilliant. In terms of tolerability and effects, were so great that it became like for me a complete what's the word, but constant, or one of the most important tools in my toolbox. Which again, 10 years plus ago, I'd never used. I didn't know it even existed. Yeah,
Mhm.
but it's great. Yeah, and I do use HMOs from time to time too. Um, and again, probably some people were they might be too sensitive for lactulose, GOS, or FOS, inulin, where we want to increase bifidobacteria, but we can't use some of those other tools, which can have, I would argue, more profound effects in the microbiome, um, but they're more gas forming, broadly speaking, for most people.
I was at about 2 to 3% Bifido, and HMO took it over 8%.
Yeah. Okay.
So yeah,
What sort of dose
that's
did you
pretty
get up
much all
to?
they eat, right? Bifido,
Well,
yeah.
I mean, they love lactulose, they love Goss and Foss too,
Mm,
but yeah, and some strains like Infidus obviously loves HMO specifically. But what sort of dose were you
right.
using? I'm just curious, Rich.
I was only using one. I started out with just 1 gram a day.
Okay,
Yeah,
that's cool. That's
yeah.
that's a good response. I wouldn't say clinically I would see that from that dose of HMO in most people, but I'm glad it did for you.
It could have been
That's a
because I
lovely
had
bloom.
yeah, for sure. I had a base of 4 other prebiotics that I was taking that got me up to 3%. So maybe there's a
Yeah, got it. So
combination,
maybe the
not
combination
just
that we had, the
HMO.
synergy. Yeah, might well
Yeah,
have been a synergy effect. Great. Yeah.
sure. I appreciate though you mentioning lactulose and as your unapologetically your favorite. For listeners in the United States, I think it still requires a prescription. I don't know
I know
why
it's
that
a
is.
weird thing because the US market
Mm,
is so unregulated in so many ways, but not with
right.
lactulose. It's no more dangerous than magnesium or vitamin C that, yeah, if you took enough of it long enough, you get diarrhea that might result in electrolyte issues. you know, Similar sort of risk profile there. Um, but yeah, it's such a benign something used to be added to infant formula in the 1960s. It was an idea before its time, but as a way of making essentially it's a bifidus factor that when babies had formula with lactulose, they became dominated by bifidobacteria. And if they had normal formula, they were dominated by wide range of like Bacteroides and a really diverse ecosystem, which we don't want. But that was way before people were open to the idea of prebiotics in infant formula, so that didn't last very long. But it's such a benign thing. But yeah, I think US is the only country in the entire world where it's regulated as a
Oh my.
pharmaceutical versus everywhere else it's just sold in the chemist. Yeah, pharmacy, yes, it's in the laxative section, and yes, in large doses, does work as an osmotic laxative. But we're talking quite different dosages. Like typical laxative dosages are 30 or 40 milliliters in one hit,
Oh
whereas the
wow.
minimum dose for have a prebiotic effect is probably just like 2 grams, three mils, so it's like 1/10 the kind of dose. And yeah, there's definitely a dose response. We get bigger microbiome changes with higher doses of lactulose, and that's clearly been shown in studies too. And in my practice too, like bigger doses cause much more profound changes. But the minimum dose is just like 3 milliliters, which is a pretty small amount. And for many countries, it's immensely cheap too. Like in Australia, we could buy 500 mils for $10, and
Mm,
that's like, over 3 months supply for $10, which is like absolutely fantastic from a price point. And again, it's a sweet syrup, so compliance tends to be pretty good from a taste perspective anyway. But it does increase gas. Yeah, and that's where, again, slowly increasing the dose. But and again, probably the only caveat where it can be problematic is SIBO cases where they have bacteria that eat lactulose in the small bowel. I think that's the area where it would be contraindicated. To my mind. So, there is a patient cohort where I just don't go, hey, take and potentially with some people with high methane to excess methane production in the gut can react poorly to lactulose too. They're not all. Some actually it works really well as a laxative and can be therapeutic, but others will just blow up like a balloon and their concentration gets worse. So there's a couple areas where you've got to be cautious around the use of lactulose for sure.
well, you motivated me. I'm gonna get me some. Yeah, I'll
Yeah.
get a prescription for it. If of course I have to, so I will.
Yeah, I know some US patients just order it online from a chemist in Canada or even Australia, and just get it shipped over.
Oh,
But yes,
okay.
you can get shipped for it. Just make sure, again, the US market's strange because they like adding fluorescent pink and artificial colors, artificial sweeteners, and things to the lactulose. So just don't get any with those things in it. It's supposed to be crystal clear liquid that's already sweet, and it's blown my mind that they bother adding artificial sweeteners to it because it's already sweet. It tastes like sugar
Mm,
syrup. Like, why would you have to add more?
mm.
But for the U.S. market, they do. They make it fluorescent pink and green and orange and add more sweetener to it. So avoid that brand. I think there are brands that are clean in the U.S., but they're hard to come by.
Okay, that's a good tip. Thank you.
Yeah.
I'm guessing you're familiar there on Facebook. There's a 16,000 member gut club stool test discussion group, which, the normal person isn't interested in that, but 16,000 people are.
I reckon there's
And
probably even more than that who just don't know it exists. But
yeah,
yes, I
for
hear you.
sure,
Yeah.
for sure.
Yeah.
And I find a lot of very sick people on there and a lot of
Yeah.
very smart people helping others. I appreciate that. And I just mentioned that I had the opportunity to interview you and what questions they might have. So as time allows, maybe I could throw a couple of those questions at
Yeah.
you.
Yeah.
This first one's a little bit longer, but the question is, how important is it to you that your clients be assessed for potential non-gastrointestinal risk factors like biotoxins, environmental toxins, improper immune activation, damage to immune cells, like with chronic Bartonella, medical therapies, certain enzymes, nutrients, including COVID vaccine, its immunological, toxicological impact, harming the natural form and function of the gut. So all of those things together.
I mean, I think as a clinician, like when I first see patients, I spend 90 minutes with them, and a lot of that is a history taking. Yeah, going, I want to hear your story in great detail, and you're really trying to, and I do look at, obviously I spent 25 years researching the microbiome and treating mostly microbiome-related things. So I do look at the world through a microbiome lens. Yeah, and if you have a Lyme patient who just treated Lyme for the last 20 years, they look at the Lyme lens. So they're going to look at things differently than the way I look at things. Yeah. So it's putting that I do have a biasness towards the importance of the gut microbiome. Um, and obviously we're taking a case, we'll try to get some details there. And then yes, if we suspect something else might be at play, we might do some testing depending on the costs associated with that. I mean, I think that at least the stuff you said there, I mean, some of the things I'm probably still can't test particularly well for. Other things would cost a lot of money to do so. It's like, okay, is that the best use of resources for this person? Maybe for some people it is, some people it's not. Um, I still think that I think again, we're based on my experience too, but like just the key role of the microbiome is we can still, I mean, I would say if someone had a COVID vaccine and then their gut's been poor since then, I want to know that information. It's one of those key attributes that like, boom, I want to take that in my mind. Okay, that may have been, because we know for some people it definitely negatively impacted microbiome composition. I don't know if it did for everybody. I don't really have enough research to answer that question, but for some people it definitely did. And definitely Bifidobacteria is one of the groups that was impacted by that. So again, that's something that flags in my head, but we'll do a microbiome assessment. We'll see if that's exactly what we see um, in that case. But I think, again, looping back around that by working on improving gut functionality, and that includes things like gut permeability, gut transit time, because so many people are slow. Really, it's huge. The people have they might know they're slow. I think that's the other thing too. They might go, "Hey, I'm doing one poo a day, and I've got a type 4 in the Bristol stool scale, therefore my transit time is fine." No, you can't assume that. I've had so many patients that are actually fecally loaded who are doing one bowel movement a day and a type 4 in the Bristol stool scale and didn't know they were fecally loaded until we did some motility testing. So it's like, yeah. So I did think, okay, motility is a huge thing. Improve that, improve your gut permeability, and you improve microbiome composition. So many things improve. How your immune system functions improves. How your brain functions improves. So many things improve from that. That even if you do have other things going on, that can't be a bad thing. Doing that, to me, it's like core underlying things. And I think there's an old naturopathic idea is if in doubt, treat the gut, or treat the gut first, because we've always known that this is like where so many things emanate from. So we need to prioritize that bit. And yes, sometimes there might be other things going on elsewhere. There might be, I work with some people that are doing like mold detoxes on here, but I'm helping with the microbiome bit at the same time. So sometimes they're working on a clinician who just does that, and I'm working on the microbiome component. That definitely occurs.
Makes sense. You're just increasing their overall health and resiliency.
Yeah.
Yeah, I love it. Another question, if I can. Question asks, why are we having to wait so long to get a technology that can measure the small intestinal microbiome with DNA shotgun
Yeah.
technology? There are products being tested that use a capsule that you swallow. I got to interview professors working on one of those. They can
Cool.
take one or more samples as it goes through the small intestine. This guy ends by
Yeah.
saying, it seems straightforward, but we never get these products through regulation. Do you have much comment on that?
I think it will happen. I share that. I just, particularly with some of those patients, like if we knew what bacteria were, what the imbalance was in the small bowel, we would be able to target treatment so much better. Yeah.
Mm.
At the moment, like, oh, they make hydrogen, or they make methane, or they might make H2S. That's kind of the breakdown. But with like, what's H2S producer? Is it Escherichia? Is it Haemophilus? Is it Klebsiella? Is it Desulfovibrio? It's like, yeah, so kind of would love to get that level of detail, and I don't think we're that far off. Yeah, speaking from your gastroenterology colleagues around the world, I mean, these things are now in research centers, putting through the tests, and I think probably in 5 years' time we will have access to such tools. Yeah, probably not me as a natural physician, but gastroenterologists will have access to those tools.
Hmm. Oh,
Longer
fantastic.
term, I'm hoping there'll be such things more easily available for other clinicians like myself or the general public to access to, where if it's just swallowing a capsule that has no risk of harm with it, and the cost isn't probably going to be that much in the end. And once they get the technology working well, hopefully it'll be quite easy to access these tools. Yeah. Just like like one day I hope again, this will happen, whether it's the next 5 years or more like 20 years, but we'll have toilets that will analyze our poo instantly when we empty our bowels and give us a readout of our microbiome for the day, so we get that sort of very instantaneous feedback rather than you have to wait, 3 or 4 weeks from a lab between results. One day we'll get that.
That's fascinating. I was just going to ask you what technologies that you hope can be developed. So if you could wave your magic wand, would it be the toilet that could that could
Yeah,
identify a
yeah,
species or something
definitely.
else?
I would love quick turnaround times because I think
Hmm.
particularly for things like that where you're getting acute insult to the microbiome, I would just love
Hmm.
not have to wait 4 weeks to see exactly what the level of harm is. And listen, when there is acute insult, like not putting antibiotics or chemotherapy, we don't wait 4 weeks to treat. We'll put things in place and make assumptions around what's going on. But geez, it would be nice to get really quick results going exactly what's going on, so we can target things really specifically. So I think that would be definitely on that list. But I'd also put that small bowel assessor because of just to know what's going on with that individual person's small intestinal microbiome would be fantastic because it might make all the difference for those people, some people who are not responsive to the usual things. Yeah, that's where a tool like that would be immensely helpful. And less so when it's like people respond really well to, we can do, non-interventional breath tests. But again, this is swallowing a capsule, getting information, non-intervention too. And it might not end up being quick turnaround time, and inexpensive to do. So yeah, that tool I think would also be a major game changer too. And that one seems less far off than the toilet that will give you instantaneous readouts, but that will happen in the future. And I think the other thing would be maybe a good stool bank, um, in that when infant babies are born, we maybe take sample of their poo maybe once a year. We take a sample of their poo and just freeze it and put it aside for them in case they do need to take a course of antibiotics. Then we can re-inoculate them with their own ecosystems again. Yeah, because it takes all the concerns around um, disease transfer or from FMT. I think, but or personality transfer or metabolic health transfer, like a bunch of different things come from FMT research when you're getting poo from somebody else, a poo transplant. But when it's self transplant, we don't have to worry any of those things. Yeah, and it also means we're guaranteed to have engraftment. Yeah, and I think this will actually mean that we don't have the same level of with each generation, Westerners were getting less and less diverse ecosystems, because we can only pass on the microbes that we have. So when I was born, I was, gifted a number of microbes from my family members, mostly mom, but a bit of dad too, probably a little sister as well. And then I proceeded to take a ton of antibiotics as a kid. I grew up in the 70s in Canada, and they're like, "Oh, you've got a sniffle, take this antibiotic. Oh, you've got a slight cough, another antibiotic." It's just like so many antibiotics growing up, and my even was hammered, and the diversity went less and less and less. So I can
Me
only
too.
pass on these microbes to my kids, because of that. And then they're going to start with that, and then if they get exposed to antibiotics, which thankfully they have not, then they would be impacted, and we get less and less, and that's what we see in these Western nations. And this would fix that. Because every time because antibiotics can be life-saving. We shouldn't use them for a bloody sniffle or for, a viral bronchitis, but they can be life and life-saving. We want to use them for those things. And if we just use them for those things only, antibiotics would last us for far longer, too. From a stewardship perspective, we'd have their use and efficacy for many more years if we use them appropriately. But then we could re-inoculate with your own ecosystem, and then you wouldn't have any microbiome harm from the experience. that I think would be a game changer too. And that should be something that could be implemented relatively straightforward. And there's been some research around that in this Canadian study where they had people when they went into hospital, they took a poo transplant. They took a poo sample when they went into hospital, and they had their procedure, and they gave them a poo transplant afterwards. And those that had their own poo back given had like no C. diff infections and were at hospital so much better, and which totally makes sense. Yeah. And it is by far the best way of reestablishing your ecosystem after a major harmful event like, of course, antibiotics is not prebiotics, not probiotics, but your own specimen transplant.
You're giving some entrepreneurs out there some great business
I
ideas.
hope so. I'd love someone to actually do this. And I'd love it if we just standard practice is that we actually have a sample. And when I think people get their head around the importance of the microbiome, it's like, why the hell did we not do this before? We're giving all these interventions that are killing bits of you, standard protocol to young kids. And we have a very easy way of actually re-inoculating so they don't actually have any harm from that intervention, or we just ignore it and they get potentially lifelong harm. We know antibiotic use in kids leads to increased rates of obesity and asthma and allergies and a whole bunch of different things. It has long-term consequences, reading studies of antibiotic use in middle-aged women increasing the aging of their brain and causing cognitive decline or speeding up cognitive decline. It's like, these things are preventable if we just do a bloody poo transplant afterwards. It's like, and it doesn't not that costly of an intervention. Just getting your head around the importance of actually doing it.
I would think a company like Tiny Health, at least in the US, I understand gathering the largest database of infant, stool tests, that would
Yeah.
seem to be a natural part of their business, to offer that
Yeah, and you
support.
have to have like, special deep freezes, et cetera, and size and et cetera to actually do it. But it's not the technology exists now to do it very easily. I know there's even a US I think they're called Tend, TND, that was designing a toilet seat attachment to that you just poo into the thing you sit onto the toilet seat, you just do it by move it like normal. It collects a specimen, you kind of spin it, and then it just fills these capsules full of FMT, and you don't have to touch it or anything,
Wow.
and
Wow.
that I think I don't know where they're in commercialization now. I think it's just being used in research settings, and there might be some weird legal loopholes I have to get through because it's for FMT. But again, the stuff is there. It's doable with the current technology. It just requires people willing to do it, and yeah. But I think that could be such a game changer for so many different people because we just see and then the gut club is full of people that have been harmed from antibiotics and other things that have caused microbiome harm. And if you had a reset point in a time where your health is really good, you can use that and get that bit back.
So those
Yeah.
samples have to be frozen. You can't like dehydrate them. Would that kill everything?
This
Or,
is
or
it's a bit outside my area of expertise, but from my understanding, it would have to be under sort of minus 80 degrees and like a proper for long-term storage with any loss of viability. I think it has to be under a certain temperature. Yeah.
got it.
Yeah, and I don't
Yeah.
think dehydration would work, no. Because some of the microbes are just so sensitive to air. Like the vast majority of really healthful microbes in our colon are strict anaerobes and do not tolerate oxygen at all. Yeah.
FMTs is what first got me interested in the microbiome. I don't know, at least 12 years ago.
Okay.
I happened upon an article and I thought, wow, eliminating
Yeah.
C. diff within 24 hours and now, changing autistic children's outcomes.
Yeah,
I'm
and
just
Parkinson's and
fascinated.
Alzheimer's, so much
Oh,
potential promise for
wow.
that intervention. If you're getting good donors, and I think that's the other challenge in this modern world is actually getting people that actually tick those right boxes. And I recall a partner of one of my patients years ago, and I wish I got their names. I can remember their name now. It's lost in my paper filing system from 20 years ago. But he was born at home in the Netherlands, and he was in his like I think probably mid 30s at that point. Never had a course of antibiotics his entire life. You know, he was breastfed. His parents were kind of alternative folks, so they had like healthy, whole food, organic diet. His entire life, never unwell, medically really well, sharp as a tack, brain was firing. He's like, man, you're poo. It's like you're one in a million in that you were sort of gifted, had the best, the ideal sort of initial circumstances of sort of home birth, solely breastfed, no antibiotics, good diet all the way through,
Mm.
from living in a healthy parent. parent household too, where they hate healthy food, etc. So that is so rare, in Western
Mm.
nations. And I think
Mhm.
getting donors like that are, and yes, I could see the advantage of, people talk about getting donors from the had, hads are these sort of, tribes that are, the living way humans always have. And I think, yes, there's great value in doing that too. Whether they're the best match for for someone in Australia or Canada or US is another question from a microbiome perspective. But I think getting someone like a healthy Western, one might be a better match in terms of engraftment. I mean, again, time will tell that maybe there will be things missing from people in Papua New Guinea or you know rural Mexico or the Amazon rainforest that actually play pivotal roles that all Westerners are missing that we'd all want back. I'm open to that too, obviously, but I think in terms of a match, finding those sort of people in Western nations would be um, good for us all, and if we could actually store their food, because I think that's getting back to I'm going to be a sidetrack, but in terms of having good donors for FMT, because I think that's the thing is finding really good donors, because some centers are like, oh, as long as you clear for all these diseases, great. That's a nice baseline. Love it. But, then it's like, okay, no antibiotics in 3 months. And just eat Mediterranean diet for a week before you give a poo sample. I'm like, really?
Mm.
That's kind of the criteria we're after for a donor, like no antibiotics in 3 months. And maybe that's okay for C. diff, and probably is, but in terms of like optimal health or ulcerative colitis or Crohn's disease, other conditions where the composition of the ecosystem, not just having some microbes, matters. We need to choose our donors really well. And there are some centers worldwide that are moving in that direction and doing their best to source, really good donors with lovely ecosystems as well.
There was a company paying, I think it was $500 per sample for potential FMT.
Like, listen, if you meet those criteria, you are actually one in a million or something if you can meet all those criteria. So I can understand them being paid a decent amount to look after themselves, eat really well, and exercise well,
Mm.
etc. Do all those things so that your ecosystem is in prime point moving forwards from that too. I get that. Yeah, because they are rare. We pay for things that are rare, and actually having a amazing stool sample donator it's rare. There's good ones and there's okay ones, but finding those that are just like, the unicorns, they're not rare. They're hard to come by.
Yeah, interesting. Well, Dr. Hawrelak, you've given us a lot of your time. I really appreciate it, but I have a last question for you.
Okay.
Since this is the Resilient Biome podcast, and I named it that intentionally, right? My goal is to have a resilient gut. It may not be perfect
Yep.
all the time, but if it's resilient, what would be your top recommendation that our listeners can do to have a more resilient biome?
Oh, that's a tough one. In terms of one thing, I mean, I think you could broadly say eat more whole plant foods. That's probably the key thing that most of us aren't doing enough of. There's things we could add on to that, like buy food from your local farmers market, buy organic food, as much as you can, and buy like eat a rainbow of different colors for different polyphenols. And they all fit into that kind of umbrella as best ways of encouraging a diverse range of healthful microbes in part of your the makeup ecosystem, but also in terms of metabolites we get from them that have a range of health affirming, age-defying properties.
Thank you. It's so glorious that what's good for us is good for our bacteria, and vice
Yeah.
versa. So it,
And it's
it, it
good
just
for
makes
our
sense.
broader external environment too. Like, and for I think buying from your local farmers market from people who are
Mm.
growing stuff organically with good soil stewardship, etc. It's a win-win-win for everybody in that kind of situation. We all get better and healthier from that process.
Yeah, well said. Yeah. Well, again, thank you for your time. I wish you the best, especially as you're multiplying your efforts. I love that. You're just wanting to be able to share with so many more people, impact so many
Yeah.
more people. So we really appreciate that.
Cheers, Rich. It's been lovely chatting to you too. It's a good conversation. Yeah, I enjoyed it.
Yeah, I enjoyed it. Thank you so much.